Thank you, Raven. I'm going to share some of the points how to read the visual printout to avoid the pitfalls in the diagnosis. The single field printout comes like this and can be divided into various segments for the proper diagnosis. The uppermost part is for the patient's identity and test parameters. So verify that you are looking at the correct patient's data and the test information. Ensure you have a correct patient name put into that, and date of the birth is very important as the age is a factor in comparing the visual field results to normal. Then the test parameter confirms that specific test type and stimulus size has been used, and correct eye visual field is there. As I said, date is very important. Instead of putting the 1927 patient's date, misentered as a 1972, the visual field of the old person will be compared to the young person, and it will show you the uniform depression of the hill of vision. The strategies are very important. Usually, by default, we use the size 3 stimulus, unless it is advanced case of glaucoma, where you can use the size 5. And the visual acuity should always be mentioned, and the refractive error also. And the pupil size is also very important. Like this is the patient who was on miotic, and after stopping the miotic, we did repeat the visual field, and there was an improvement. So pupil size is also very important. Then assess the reliability of the patient's performance. So various indices are there, fixation losses or fixation monitoring. These are the two ways of doing it. Hell-Crocus blind spot method is used in Humphrey, while fixation monitoring is done in the octopus field. So approximately every 10 stimulus is projected into the blind spot area, and if it is seen, it is considered as a fixation loss. You can also use the gaze tracker video monitoring, which is at the bottom of the printout. The fixation monitoring is very good. If the cross is out of the pupil, then the machine stops on its own, and then again you center the thing and it comes. So unsteady gaze is also not a good performance. So here I have shown if there is a large eye deviation, the upward spike comes. If there are small blinks, it is an inverted small spikes. So this is a very good steady fixation. If the large eye movements are there, you have to repeat the fields and re-counsel the patient. So sometimes patient is fixating at a wrong place. So here the blind spot is located inferiorly, and here the patient is fixating at the rectangular target or at the bottom, which would be used in the patient with the macular pathology. So these are the fields which requires repetition. The false positive defect is seen with the trigger-happy patient. It gives you elevated false plus signs, and GF, glaucoma hemifield analysis, will be in the form of abnormally high sensitivity. So it will be seen as a white scotoma on the grayscale, and high positive mean defect is also seen here. The false negative field defect is seen as a clover leaf pattern, because initially patient is giving the good response, and then later on the same test point patient is giving as a negative response. And usually this repeat test is done with the 9 dB higher stimulus, and still patient is giving you negative response. Mostly this is because of the poor understanding or the lack of motivation or tiredness of the patient. Foveal threshold should always be kept on and should be correlated with the visual acuity and the mean defect. Good foveal threshold and poor visual acuity means you have to repeat the refraction of that patient, or it could be mild amblyopia. If good visual acuity is there and the decreased foveal threshold is there, it suggests the early damage. The graphic scale or gray scale usually should not be used as an interpretation, but it quickly identifies the overall depression and good for the patient's explanation. Never use this alone for the interpretation. The total deviation plots comes in the numeric values as well as probable values, and PDP is difference between the patient's response and the age-matched normal population. While the pattern deviation plot is good, it exposes the overall defect in the field of vision, exposes the localized defect. Then the global indices are there. Various indices are available. Unless you use the threshold pathology method, it is SF and CPSD is not there with the CETA test. It's a single number representation of whole visual field and overall guidelines to assess the field. The glaucoma hemifield test is a comparison of the mirror image corresponding areas in the superior and inferior hemifield, and various language form is given within normal limits, borderline, or outside normal limits. And you have to again see the patient as a whole in this. Quickly assess, Babe's curve is available with the octopus perimeter. Quickly assesses the defect characteristic and depth. Localized defect will be appearing on the left-hand side, and the uniform depression is seen as a parallel line to the normals. So analyze the visual field pattern. Specific defects, look for the characteristic pattern of associated with different condition. Glaucoma has a various defects. Optic nerve condition can be, but before you start interpreting, beware of the artifacts that is there. Determine the reliability. You might have to repeat the fields for 2 consecutive same fields and assess the evidence of damage. This is a typical lens rim artifact. Patient's head has moved back. Should be compared with the typical double arcuate scotoma here. Arcuate scotomas are narrower near the blind spot and broader near the midline. So these are typical patterns that you see with the glaucoma patients. Retinal defects are usually deeper. Absolute scotomas are there, has a sharp borders, and they do not respect the horizontal meridian like glaucoma. Now, look both the fields together. Right eye field should be on your right side and left on the left-hand side, and then do the comparison. Never read the chart in isolation. Evaluate the visual field in conjunction with the disc finding, full dilated fundus examination, or other comorbidities. Non-glaucomatous neurological fields, they are atypical visual fields corresponding to the vertical midline. They respect the midlines, starts on the temporal side first and then nasal, unlike the glaucoma fields, which are seen first on the nasal side, and they respect the horizontal meridian. Ischemic lesions can have altitudinal defect or the centrocecal scotoma. And comparison of the various fields of the same patient should be done with the same strategy. Here, the mistake has been done. The full threshold is compared with the CETA standard and again full threshold. So keynotes, make sure you are looking at the trustworthy data. Will probably take 2-3 tests to achieve the appropriate baseline. Make sure it makes sense with the other clinical findings. A visual defect must be real. To be real, it must be confirmed on the repeated test. Thank you.
Thank you, ma'am.